Good morning. Thank you for coming so early on the last day. I think we'll start our session. So our session is avoiding practice extinction, staying relevant with new technologies and techniques. So our first speaker is Vino Turani from Piedmont Heart Institute. And I just want to know my colleague Tom Nguyen will be here shortly. He had his resident presenting this morning as well.
Great. So in 8 minutes, I'm supposed to tell you what you're supposed to know for the next decade. So these are my disclosures. So it's quite interesting. This is from 1993 in the USA Today. Wireless network is not great. It's wowless, meaning that wireless, Wi-Fi is really not going to take off. This is 1993, and that there is going to be really a lot of difficulty ahead for wireless technology. I guarantee you, the 10 of us in the room today have Wi-Fi on our cell phones right now. So we have to be careful in what really the predictions are from such esteemed journals. How do we define our field now? Currently, as surgeons, we go bypass, saw, scalpel, right? This is our current state. What I would tell you that the surgeon of 2030 is going to be more like this. I think that we're going to have a super specialization in cardiac surgery, so not everybody is doing coronary surgery and a variety of other stuff on top of their daily routine. Just like the vascular surgeons have both doing open and endovascular surgery and have equal places in vascular surgery, in even their textbooks. If you look at our textbook, it says cardiothoracic surgery, or it says thoracic surgery, or it says cardiac. Nowhere does it say cardio and endovascular surgery. And just like you've seen a major transition to endovascular and open within vascular surgery, I think in 10 years you're going to see something like that, and TAVR is an example of that. And of course, the inventor from EVAR, Dr. Perotti, the treatment is best provided by the specialists who are great open and great endovascular surgeons. I think the surgeon of 2030 is going to have both skill sets. At least even in coronary disease, that they're going to have a good skill set. And the cardiac surgeon of 2030 will have to pick a niche and will have to concentrate on it. I don't think that even in smaller programs in 2030 that there will be a capability of doing everything. If you're a minimally invasive bypass surgeon, you're going to need to be able to do a robotic or a hybrid revascularization just as well as you do an open beam operation, and it goes on and on. I think heart failure, specifically the third topic there, will grow the most, and I think that's going to have to be where the surgeon is doing open VADs, but then turns around, and the second case is going to be an axillary artery implantable or percutaneous VAD. I think you're going to have to be able to do both. We currently have aortic surgeons who don't do both. There are 5 in the country or 10 in the country, but I think that's going to be ubiquitous, that every open cardiac surgeon who does aortic surgery can turn around, and the next case can be a TVAR or a snorkel. So I think those are going to be important. The 2030 surgeon has opportunities. They need to own the clinic. Right now, there's people who give lectures do this, but not all cardiac surgeons are doing this. You have to own the clinic. You have to be an equal participant. Right now, the surgeons that are giving talks about imaging, they do the imaging, but most cardiac surgeons are not doing their own imaging and understanding it as well as a radiologist or a cardiologist. And they have to participate in the patient review and decision making. We say that we do this, but when you actually look at the cardiac surgeons in practice, they're not doing this. And you have to have more than just your PA or your cardiac surgeon colleague who is your ally. You have to have every single member of this team be your potential ally or mentor. And I think in 2030, the toolbox for MR will continue to grow. And the cardiac surgeon, most cardiac surgeons now do not do this. And I think that you've got to be able to do all the nips and tucks that the toolbox of MR will allow you to do. And I'm just going to concentrate on mitral regurgitation for this because overall you have to own the entire disease of mitral valve, not wait till a cardiologist calls you and says, can you go do this operation for me? In 2020, the toolbox for MR are these 3 things: a repair, a replacement, and MitraClip. And this is all that we know how to do. And quite honestly, less than 10% of MitraClips in the country are done by cardiac surgeons or have them involved. So we can say that we do it, but it's the people on the podium who say that they're doing it, but most of the country is not participating in this. By 2030, every cardiac surgeon who's interested in mitral valve disease should be able to seamlessly do all of these techniques. They need to be able to do repair, they need to be able to do replacement, They need to have MitraClip, Pascal, Harpoon or Neocord, and transcatheter mitral valve replacement as a seamless part of an extension of their repertoire. And here's a conversation that I can have now today with a patient of mine who needs mitral valve surgery. And on the bottom left, as a surgeon, by 2030, you should be able to be the first operator in any of these techniques I've shown to the right. Right now, less than 1 to 2% of surgeons in the United States can do this. We have to get away from that. Or when it comes to the disease of for valve disease, we will become dinosaurs. So you have to be able to do minimally invasive. You might choose robotic. Either way, you have to be able to do this. And it can be any type of patient population. You need to be able to do this type of operation. You need to be able to do a transapical mitral valve repair. This is me doing a neocord operation where I'm replacing a neocord on a patient. We don't need the volume. You can turn the volume off. But here you are, where you're basically doing a chordal repair transapically with a heart beating. So I think this is something that shouldn't be rare. Right now, there are less than 30 of these done in the United States. I would like for every surgeon who's interested in mitral valve disease to be able to do this. And here's a transapical mitral valve replacement. Again, 30 or 40 of these have been done in the US. Every surgeon should be able to do this. By 2030, every cardiac surgeon interested in mitral valve repair or mitral valve surgery should be able to do the last two slides where it's not in your repertoire now. So in 2030, your OR schedule should look like this. In the morning, you do a transeptal mitral valve replacement for a functional MR in an 85-year-old. That's your 7:30 case. By 9 o'clock, you're starting your minimally invasive or robotic mitral valve P2 repair in a 35-year-old. And then your afternoon case will be a MitraClip in a 99-year-old with a P2 and an A2 flail. And by 1 or 2 o'clock, you've done 3 mitral valves using 3 different techniques, all done by you as a surgeon. So you never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. The field of cardiac surgery is exciting, it's invigorating. It is important for the surgeon to own the disease. This is really important. Just don't do one part of the disease, own the entire disease. And don't just be a technician. Understand the pre, the imaging, the intra, and the post-op care. And be just as great with a surgical valve therapy as you are with a transcatheter valve surgery. Don't choose one or the other. The right surgeon in 2030 is extremely qualified for understanding the different patient populations and is an equal partner with a cardiologist. Thank you very much.
Thank you. Any quick questions? I have a question then, just real quick. Are you then following your mitral patients before instead of letting the cardiologist follow them if they have any
no, we
mitral
actually,
disease?
we actually have, I do get a lot of mitral valve referrals directly, and I bring all of those patients to our valve clinic. Every Monday and Tuesday, we have an entire day of just dedicated valve clinics. So on Monday, we have 2 surgeons and 2 cardiologists in the clinic, and on Tuesday, we have a surgeon and a cardiologist in the clinic, and they're actually booked on both of our schedules. So every mitral valve case is seen by a surgeon and cardiologist. Yeah. And then we follow them longitudinally also.
With them. Yeah,
Yep.
that's great.
Yep.
It's a nice model.
Yep, Ira?
So is the model set up then like an institute? So you guys are each salary, there is no competition for cases, and therefore you equally see the patient?
So the answer is no, and I'll just repeat that in case you didn't hear that. Is the salary structure is such that you're an institute and everybody's salaried and there is no RVU? The answer is no, we're not. Everybody, quite interesting, in our department, everybody is RVU based except for me. I'm not RVU based. And so, but the rest of the surgeons are RVU based, as are the cardiologists. However, there's such a decision to mesh the way that we're going to treat valve disease that it hasn't been an issue thus far. And I think as long as the volume stays robust, it won't be an issue. If our volume plummets for whatever reason, I think it will become an issue.
Thank you very much.
Great, thanks.
Our next speaker, Robert Cifolio, will be speaking on what will the thoracic surgeon look like in 2030.
Okay, well, good to be here. And actually, let's go back to that slide because, Ara, why don't you come up and give the talk? That's exactly what my talk is about. And I think for those in the room, if you're RVU based and it's all about volume, you're screwed, you're going to lose. Trust me, I've been on that wheel for 20 years. Every year you got to do 5% more, 7% more. I mean, many of you know that I did over 1,000 operations a year for a decade, and they were fun, but I had both my knees replaced 5 weeks ago for a reason. There's a cost, physically, emotionally, and it's not about that. It's about quality, quality, quality. So this talk is not going to be from the perspective of a surgeon, but from the perspective of a healthcare system, which is exactly what you're going to, right? Because if it's about RVUs, then you're competing. And if it's about silos, if you're a department chair, you have a very myopic, very selfish view of the world, and that doesn't work. And even if you're a COO like me, I have a selfish view of the world versus the other hospitals in New York City, and I shouldn't. We should see us all as really people swimming in the same ocean. And if we did that and didn't see other hospitals as competition, we would do better. So how do you do that? So I'm going to give you my 2 cents. It's going to be a little off the topic, but I think it's going to be more valuable. Let me tell you about what the robot's going to be like in 10 years, because somebody else can tell you that. So this is more the view of COO. So my financial disclosure, I don't have any over the last year and a half, but I have some in the past. I have to list them. They may have subconscious bias. I'm having all our executive vice presidents go through that. You have to be aware of subconscious bias. And I'm not going to list my books because nobody cares. I do think we have a lot of visitors come, and I think they don't come to watch us operate. If you do, you're wasting your time. But you should come and see how we turn the rooms over now in 37 minutes. How the anesthesiologists have to get the patient in the OR. We have to make an incision in 24 minutes. We have to explain why. At the end of the case, if the patient's not extubated in 11 minutes, they have to tell us why. If the surgeon or anesthesiologist are late to the OR 1 minute, they have to call me and tell me why. Got 2 sob stories yesterday. Just took an OR away from one of the chairs yesterday because it's the 3rd time the person's been late in the last quarter. What do you think that did to first case on-time start? When I took the job, it was 64%. It's now 97% last month. It's not easy to change culture. It's what you measure. So if you want to come and see how we do this, and it ain't easy, and it's hard to sustain, and believe me, we got all kinds of problems, but some of the things we pick away at, we wanted to start the ORs on time and get surgeons home early to their families. That's where we started. Then we started getting surgeons hats. Took me 6 friggin' months, but we got them hats instead of the stupid bouffants. We got the PACU out of there faster, et cetera, et cetera, et cetera. So I think the surgeon in 10 years looks exactly the same, unfortunately, as the surgeon today to the eye, except for some obvious things. There's going to be greater diversity, thank God. There's going to be more women, there's going to be less white, and we're going to be older. There's going to be a lot of positives from that, although the older I'm not so sure. We're going to be much more metricized, ARA, for team outcomes, not individual outcomes, because that's what first case on-time starts measure. It's not the surgeon being there, it's anesthesia, surgeon, nurses. The outcome is based on the surgeon, the nurse, the anesthesiologist. So we give team groups, and I will tell you that we started something last year in bonuses. If the hospital doesn't make a 3% margin, no 43,000 people at NYU get a bonus. So if we ain't doing well as a group, no one's going to get their bonus. Now, there's some people have bonuses that are metricized in their contract, which we can't grandfather out, but that's what we're doing. You'd be surprised how quickly people start throwing away stuff and they start reducing costs when they say, I've done a great job and I'm not going to get my bonus because the 10%'s bad. Changes how you look at things. The reality is we're going to be much better standardized, dramatically more standardized in terms of things that we do, and I'm going to show you how we do that. But the single most important bullet I have in this talk is this. It's not learning a new skill in the OR. It's not learning, although some of the stuff that Vina talked about is important. It's really better leadership skills. And this is where we as surgeons do the worst, because you don't get to where we are if you're a great leader. You get to where we are because we're great competitors. So if you can learn leadership skills, become more coachable, and have a smaller ego, and your confidence will be fine, that is the single most important thing you can do, is invest in yourself. Either get a coach, do 360s every year or 2, invite people to criticize you with real honest criticism. That's the single most important thing that'll get us better. And the reason is it's all about quality. So I'm going to just end on one metric we're doing to do this, because every time I look at administrative databases, I hear how they're not fair. And the surgeons do nothing but punch holes at it. This is no good, that's no good. So we decided we would stop that a couple years ago. We developed this efficiency quality index. What does that mean? Well, if you're baking a cake and we measure people in the cafeteria or people who change beds, how long it takes them, if you say my quality is the best in the world, I'm the best robotic lobectomy surgeon in the world, but it takes you 14 hours, it doesn't matter. So you got to stop talking about quality unless you divide it by a rate. So I'm sick and tired of hearing quality, 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 unless you add a time. There has to be a time element to it. And yes, if you're a very slow surgeon, that's bad, even if your outcomes are good. Because the patient is in the operating room longer, you're taking away opportunity from other patients to be there. So the efficiency quality index is a sum of a weight of quality metrics that you, as the individual participant, decides what they are. If it's making a bed, you can tell me what's a quality bed make. If it's making a hamburger, it's what's that. If it's a lobectomy, we can list them. The higher the score, the better. And the quality index is based on what you value and what your culture is. And so here's what we do for lobectomy. Observe to expected length of stay matters, because you saw 212 cases today. We only have 740 beds. You got to get the people the hell out to do the case the next day. It matters to the hospital. It matters to patients. Readmission rates, hospital-acquired rates, surgical site infections, the amount of variable direct cost per case, and that's been very effective for us. The number of OR minutes used, et cetera, et cetera, et cetera. And we put a weight by these. Then we give each surgeon his or her score, and they can say if their data is wrong or not. But they can't throw out any data point unless the 6 or 7 or 50 people they're competing against agree. So now the surgeon can't say the data's not right, and now the participants can't say we're not measuring the right things, because you tell us what to measure, and it's your data. And what do you think happens when you start giving people scores? We're now on our 4th iteration of this, and we went from a non-ranked lobectomy program to a 3-star lobectomy program twice already since we've been there. So within a year and a half, we literally took a program that was good and made it in the top 6 or 7 programs in North America based on the STS database. And you can do that for everything. And it is validity over quality, and I'll skip this, but you know what it's about. The point is, if you take that and apply it to an organization or an institution, and you measure every researcher, everybody who's making a hamburger, everybody who works in pharmacy, and make every one of them develop their own EQIs, what do you think happens to the culture? Well, the hospital gets better, the medical school gets better, the employment engagement is as high as it's ever been, and you have people now being compared on things that are actually meaningful to them. In addition, you may say this stuff is baloney, but we all say quality, quality, quality. Well, how do you measure it? You got to have some yardstick. So we're now 5-star, not 4, but we'll be 5 in CMS, the only 5-star CMS hospital in New York City, an A in Leapfrog, and all the other things. The one that does matter is Vizient. The Vizient data, if you don't know it, you should look at it. That is a very highly metricized one, and that one matters. And that one we've been 1, 2, or 3 in the United States. And Rush and Mayo Clinic are the other 2 super performers in that. So I think to conclude, you want to be part of a higher ambition. I understand we got to worry about our own salaries, our mortgage, I get it, our own bonuses, but it's got to be about something more important than that. We give a citizenship score for how you treat residents, nurses, et cetera. And it's about the mission as well as the money. The money will take care of itself if you have a higher ambition, you treat people well. That's what our hospital in Brooklyn is in those programs. You have to have investment in the community. If your employees don't feel like they're part of something bigger and more important than money, you're going to lose. So community programs that resonate to your employees improve engagement. And we have a whole bunch of ideas I can share with you later, even including a talent show that we're now doing for the 2nd time, which has helped. Finally, the best improvement you can make to be better in 2030 is in yourself. And understanding your own triggers, understanding your wellness, how well you sleep, how much you work out, your nutrition, be better leaders and more inspirational to those around you. Thank you.
Thank you very much. So insightful. Any questions? I just have a question.
Yeah.
How much resistance did you meet in starting these initiatives, and how did you
Enormous,
deal with that?
including an email this morning. Well, I mean, the reason is you have people who are older than me, been there much longer than me, been there a couple of years. They're not used to reporting to a COO, they're used to reporting to the CEO. They don't want to be scored because everyone thinks they're the greatest thing in the world. And when the first 6 months is the realization that you're not. And the only way to do it is to give them data they can't shoot holes at. And the only way to do that is to allow them to say, okay, you tell me what's quality, and here's your data, and then you tell me if it's wrong. But you can't throw a data point out unless, let's say there's 9 neurosurgeons. The other 8 neurosurgeons say, oh yeah, you're right, this was a redo craniotomy that had radiation. It shouldn't count in a primary craniotomy. And that's what we do in thoracic surgery. We do it for lobes, segments, and we're starting to do it for esophagectomy. We don't do enough esophagectomies right now to have a EQI. There was a lot of resistance in the physicians, but interesting, the pharmacists, the staff, the housekeepers, they said, look, a C. diff bed is different to change than a non-C. diff bed or a surgical versus medical patient. We let them make up the rules. And now what we do is we celebrate the winners as opposed to punish the losers, and everybody comes up. But there's still a lot of resistance.
Dr. Cifarlia, we all know you're a very busy thoracic surgeon, but now it looks like you're taking on a very busy administrative task as well. How do you balance all that?
Not well.
And work out at the same time?
Yeah, so not well. I'm not doing that well. My knees wouldn't be this swollen if I was. But so when I first was offered the job, the dean said I could operate once a month, and I'm like, bro, would you go to a surgeon who operates once? So I operate 2 days a week. I do 2 cases Monday and 2 Wednesday. I try to get out by 12. And then, do my administrative stuff. So I think it's really important that people in the C-suite still see patients and operate, because A, doctors respect you, and B, you really understand the physician's life better than anybody. And it's why our engagement is up, and why our MD's salary is now up higher than ever, because we respect and understand what they do, and that makes them feel engaged. I think when you stop doing that, you lose some credibility and respect. On the other hand, I'm not sure what the right balance is. I only did 190 operations last year, which for me was a lot less. But the year before in New York, only did 260. So you can't do 1,000 operations in the system, and it's impossible. Jessica can tell you probably the most you could do at NYU is 350 as one surgeon, something like that. Yeah, you can't run 2 rooms. So I do think it's important that in your hospitals, you should make sure that your administrators are seeing patients, or some of them. And if they're not, there's a disconnect.
Thank you.
All right, thank you.
Thank you for your excellent presentation. My name is Tom, and I apologize for being a little bit late. I was giving a talk in another session. The gist of this session is to really look into the future and figure out what we need as cardiothoracic surgeons to stay relevant. We talked, the first 2 talks were about what cardiac and thoracic surgeons will look like in the future. An important element of being a cardiac surgeon is transcatheter skills, and our next talk will be by Dr. Yoshi Kaneko at the Brigham, and he'll talk about step-by-step guide in starting a transcatheter valve program. Dr. Kaneko.
Thank you, Tom. So my title is Step-by-Step Guide Starting a Transcatheter Program. So the objectives are to acknowledge the current state of transcatheter therapies and the steps needed for the growth of the transcatheter program and utilizing your own program for improvement. So this is a slide shown by Dr. Bavaria at this meeting as well, but the TAVR surpassed the number of isolated AVRs in 2016, but in 2019, even if you'd add all the AVRs, including concomitant procedures, the root procedures, and everything, the TAVR will be performed more than those of all included surgical AVRs in 2019. So what he has mentioned, this was in Chicago, but in 2020, there's no T in TAVR. So TAVR is the standard of care in this era. And this is from the TVT registry. There's over 600 institutions in the United States that perform TAVR, and with the changes with the national coverage decision from the CMS, that number is increasing. And it's not just TAVR. This is from the MitraClip, and the MitraClip sites are slowly but gradually increasing, and the most latest number will almost reach 400. So in reality, it's not starting a transcatheter valve program at this point. It's more of how to grow a program. So I sort of changed the title here a little bit. So sort of the history of our transcatheter program at the Brigham Women's, we first started doing TAVRs in 2007 and MitraClip in 2008. And we did have an engaged surgeon from the start who was cross-trained and was invested in the success of the program, which is the key, which I will sort of emphasize later on, and slowly grew the infrastructure as the clinical volume grew. and now became the highest volume center for TAVR and MitraClip in New England. So this is sort of the growth of our program, so it has grown over time. And just to quickly show the growth of our team as well, we started with 4 members back in 2011, and now we have 13 members. And as of 2019, we have 21 members, including a lot of research coordinators, the valve coordinators, not just the non-physicians, but the physicians have increased as well. So cardiac surgeons, interventional cardiologists, but also imaging cardiologists, senior cardiologists, and most importantly, cardiac anesthesiologists. So we do participate in multiple clinical research, which has been the key. And this is what our weekly schedule looks like. So nowadays, we do TAVRs almost every day. We cannot perform enough TAVRs to see all these patients and consume them, otherwise it just gets piled up. And we have opened up another team, and we sort of alternate in performing TAVRs and have 2 clinic days. So we see about 10 to 20 new patients and do about 7 to 15 cases per week. So what did we learn over the course? This is sort of the main chunk of my talk. So I have 7 tips for starting or growing a transcatheter program. So the tip number 1 is that a team needs to be built, not forced. So of course, the most important key to this is the cardiac surgeons, I believe, because who is going to stop these cardiologists from performing TAVRs on a low-risk patients that are not really suitable? And all the successful transcatheter programs has a surgeon presence in their program. And I have to say that the cardiac surgeon must be involved in these team-building process. And of course, interventional cardiologists, they have the most wire skills. I took this from one of the interventional cardiologists' Twitter, and this is what it says. They feel like they're a Superman. So you gotta sort of hold on to them a little bit. So this is anesthesiologist. I love this cartoon. But the cardiac anesthesiologists are the key to the program. It might not show in this cartoon, but they are a key component to our program. Of course, the imager, cardiac imager. But most importantly, as you build the team, they're not just going to be colleagues, they'll be your friends. And I think that is the key to successful team. And you become more than just a colleague. Number 2 is to invest on the non-clinician needs. So valve coordinators, the clinical coordinators, and most importantly, the administrator who really helps us bridge between the patient and the clinic. These are all very important, and you sort of have to gradually invest on these non-clinician needs and grow your program. The tip number 3 is to understand the impact on ancillary services and your ability to provide care. So 2 of the bottlenecks that we have in the transcatheter program, 1 is the capability to get a CAT scan, so you need a CAT scan slot, and also the clinic slots. So the CT scan slots and clinic slots, we sort of have to constantly open new ones to accommodate for the growth of your program. And not only that, we have opened up a non-proceduralist clinic. So a cardiologist sees a patient on their own who does not perform TAVRs. And if they feel like the patient needs treatment, then they will get referred to us. And it happens to be our non-proceduralist clinic is Pat O'Gara, so you can fully trust on him when he refers patients to us. We also opened up another valve team when the growth occurred, and we're also planning to open up another valve team to accommodate for the growth. But most importantly, you have to act before the impact is felt. So when you start feeling that growth in your program, that is not when you should act on it. When you think that your procedure is going well, before the growth happens, that's when you have to act. And I think that is a very, very important tip because we did get behind in certain times, and that has hindered our growth. So get involved in research. Back in the partners' original days, there were only about 20 sites that were involved in these clinical trials. But when you look at the recent clinical trials, there are over 60 sites. So there are more opportunities, and the industry is looking for partners. So you have to find a good research coordinator. But what it does in research is that it sort of creates a spiral effect. And you get more patients from the cardiologist because you do something that is new. And you will sort of be differentiated from other programs. So number 5 is constantly assess your outcomes and identify deficiencies and opportunities. So clinical outcomes are very important. Fortunately for these TAVR outcomes, we do get TVT registry data. Find a deficiency. If your outcomes in length of stay is really long, then you have to do something different to improve that. You have to have monthly M&M and sort of critically review your outcomes and try to make that clinical outcomes better. And if you think that clinical outcomes are good enough, and if you think that you're doing well, then look at what your neighbors are doing and do what your neighbors are not doing. So some of the things that we did was total percutaneous approach for transfemoral TAVRs in the early phase. We did constant sedation, next day discharge, some of the things that people were not doing. And one of the things that we're trying to implement is this 2-week rule, which I will mention at the end. So tip number 6 is to discuss and assess the referral patterns as the indications evolve. When we first started doing TAVRs, it was sort of simple in our head. You know, we had the standard referral pattern where internists referred to cardiologists and the cardiologists referred to us. But as the program and the indication grew, this is what we're seeing right now. It's the general internalist referring directly to the program. Local cardiologists, institutional cardiologists, and even other surgeons. That is actually one of my big referrals. So other non-TAVR surgeon or non-transcatheter surgeon will say, hey, Yoshi, can you do this one with transcatheter technique? Because I don't think the surgical outcome will be good if we did it open. So, you know, one thing that you can look at is there a place where surgical referral is coming, but not a structural referral? So you can look at that and dissect it out and increase your referral patterns as well. So the last but not the least, engage decision makers and leadership. I think this is critical. So hospital leadership, they can provide you with financial support. You have to show the numbers, and you have to show the growth and the finances, and discuss the capital needs, and discuss the programmatic support that they can provide us after showing the numbers. And if you can persuade them, that'll grow the program further. So the division and department leadership. So in this particular case, it's usually CT, surgery, and cardiology, and you have to align the goals and provide adequate personnel available so that you can support the growth. So this is some of the financial data that we sort of review, and this is something that we actually brought to our COO, not you, Dr. Folio, but you know, we show it to them, and we say that we need more personnel, and they actually increased our non-physician support by 1.5 FTE. So I think providing these financial data is critical. So what are we doing right now? So we're trying to implement this 2-week rule where patients are evaluated within the 2 weeks of consultation. And then the patients, after being seen, will be in the procedure room within the first 2 weeks. And this is something that we're trying. It's actually very hard, but you know, this is one of the goals that we're trying to implement. And number 2 is to try to get a better flow with the inpatients. When we looked at our own data, we saw that our inpatient TAVR length of stay was extremely long. So we are planning to hire an inpatient PA so that we can expedite that process with continued patient care. So I think in the days of transcatheter, it is important to grow your program, and the surgeon must be in the center of it. Thank you very much.
Thank you, Yoshi. The floor is open for any questions. Yoshi, you showed your clinic schedule, your TAVR schedule is pretty busy, 5 days a week doing TAVR. How do you balance that with being a surgeon and doing surgical cases, 1? And then 2, how do you balance being a transcatheter surgeon and a surgeon's surgeon, but also be respected as a surgeon's surgeon? Is that possible? Can you be you know, a good surgeon's surgeon, but also be in the cath lab all the time and not necessarily doing some of those complicated cases?
Right. Great question, Tom. I think I'm still struggling how to manage this. You know, we have 4 to 5 days of TAVR. I usually cover 2 to 3 days, and my OR schedule is also busy. So right now, I'm trying to dedicate the TAVR days to just TAVR. But you know, we have these emergency cases that sort of come in, and we sort of sandwich it in between. And I think the busier you get, you tend to want to keep the surgical cases, but I do give away some of the standard cases to the juniors so that I can accommodate the schedule. So it is sort of a challenge, but at the same time, I think it is manageable. And it sort of goes to your second question. I think the surgeons must perform surgery in order to stay relevant as a transcatheter surgeon. So I think we have to be doing open surgeries, a lot of complex cases, in order to have the say in the conversations, especially at the meetings. So we can never throw away our scalpel, even if the transcatheter is your focus.
Do you feel a pressure with RVU targets? Obviously, you could be upstairs doing you know, an ascending or AVR, MVR, and have, you know, easier to meet your RVU targets than doing a TAVR. Is that a pressure for you, or how do you suggest folks balance that potential pressure from administration?
Yeah, absolutely. I think we can get short-sighted, right? So, RVU productivity is very, very important, and that will sort of determine your salary. But at the same time, if you look forward, right, what's going to happen in our specialty? You saw that graph with the TAVR numbers constantly increasing, and we definitely have to keep that in mind. Our practice in the future will have to involve transcatheter therapies. And to be short-sighted, to just gain that RVUs in a short term is great. But at the same time, I think you have to negotiate with your hospital, if you are a transcatheter surgeon, saying that, my RVU targets should not be the same as a fully open surgeon because of the future investment that your hospital is going to make. And I think those have to be separated.
Thank you. Dr. Voportian.
So this is probably not a question directed solely at you, Yoshi, but to other thought leaders in the room. As we start doing more and more TAVRs, as you're doing, it reminds me of doing more and more EVARs on aortas. You just said that as a surgeon, we should remain in the operating room, and those cases will be complex. Well, as an educator, how am I going to get my trainee to move up the complexity ladder and learn and cut his or her teeth on the easy cases when all that's left for surgeons is the hard ones? And this is something that I know the vascular surgeons are struggling with right now. They are doing all EVAR and all percutaneous and no comprehension of a complex, high clamping abdominal aorta, something we all aspired to do during our training. So I know you can't answer this right off the bat, but some of the comments you made, if you think, 10, 15 years into the future, I just wonder how we're going to do that.
Yeah, I agree. The training of the young surgeons that are upcoming in this era is going to be extremely hard because the standard low-risk aortic valve replacements are going to go away. Not completely, but the volume will significantly diminish, and that was sort of bread and butter of these cases. I don't know if lengthening the training program will accomplish that. Maybe milestone would be something that is important. But at the same time, I think we're going to see something that we haven't seen so far. So say, for instance, the TAVR explant. So to explant the TAVR, I think we started seeing some early signs and experiences, and those have been somewhat challenging. And I'm pretty sure in 2030, there's going to be a specialty called TAVR explant cardiac surgeon. And I think there will be a new frontier that the open surgery will address. So hopefully that'll accomplish what you're saying with the complexity of the case.
Just a comment, we're not going to make it longer. That ain't going to work unless you got a new generation and culture coming up that I'm unaware of. You got to make it shorter. And you're going to have to use simulation and other ways to train differently. So that's true for everything we do. We're under the gun for quality and time and efficiency. How the hell do you teach? So you have to find novel ways to do it. And the training is going to be shorter, not longer. And it's got to use novel things, simulation, artificial intelligence, mental training, et cetera. So in terms of training, ours right on that's where our highest challenge is. And we're way behind on that. We got to get much more innovative and figure out ways to do it.
I actually wanted to get Dr. Robert Guyton's thought. There are a few people in the room that have trained as many surgeons as Robert Guyton in an incredibly large program. Dr. Guyton, what are your thoughts on how to train surgeons to be surgeons, but also to be transcatheter surgeons? What's the secret sauce?
I don't have the answer, and I think it's a problem that I think we think about frequently. I do agree with Surf that simulation has got to be a big part of it. I do think that beyond simulation, there is also potentially surgery on either cadavers or live animals in the animal laboratories. I do think we may have to move to working on non-human operations. You may have to do 10 porcine mitral valve replacements. You may have to do 10 porcine AVRs because we're not going to have the human sources to do that.
Just real quick comment. In addition to training residents and fellows, we have to think about exciting the next generation, especially as we have these I-6 programs, right? So it's been shown that you get a medical student just to touch the patient, to throw one stitch, that excites them into getting into the field. But as we're doing more complex things, more wire work, et cetera, where's the medical student? They're standing in the back of the room. They're not doing as much, and we have to be able to excite the next generation. And that's something that I don't have an answer for that right now, but we have to be able to do that as well.
One last quick question. Show of hands, how many folks in the audience have an active TAVR program that they're involved with? So relatively most. How many have an active MitraClip program that they are individually involved with? So a lot less. So we talk about transcatheter programs, and I think TAVR's the cat's out of the bag. It is what it is. And the nice thing about TAVRs is there's still a surgery requirement, but for MitraClip there isn't. But MitraClip, the mitral space is just as important, if not as important, because we know 30% of cases that we do as cardiac surgeons are in the structural heart space. So what suggestion do you have for surgeons to be involved in the MitraClip space?
Yeah. So mitral procedure is going to be an uphill battle for us because the CMS does not require surgeon presence in the room for these MitraClip procedures, and this will change. And if you look at the future, you have to have a transeptal technique or some sort of that skill in order to accommodate, because that's where the future is going. So you have to have a transeptal puncture skill in order for the surgeons to be relevant in the space.
Thank you. Our next speaker is Elliot Survey from the Leahy Clinic, talking about the step-by-step guide to starting a robotic thoracic program. Thank you.
All right, great. Thank you very much. I want to thank the Society, the moderators, and the program committee for giving me the opportunity to speak about starting a thoracic program. Yoshi, I have to get that anesthesia slide from you. I love that.
Yeah.
So I do have a disclosure here. I am a proctor and consultant for Intuitive Surgical, but this has actually afforded me the opportunity and really the privilege to have seen many different programs and be involved in their inception and growth, and that has informed some of my comments today. My goal here is really to provide a clear, stepwise approach to starting a program, which is obviously a difficult thing to do in 8 minutes, but we will try. But really focusing on pearls for sustainability and, most importantly, pitfalls to avoid. So I want to jump right into it. So step one, I think, is really building your team. Before you do anything, you need to know who is going to be part of this team, and the why is critical. The why do robotic thoracic surgery is outside the scope of this talk today, but you have to understand, and this actually will parlay into step two, which is talking with leadership. What is the long-term value here? Are you an open surgery program seeking a way of doing more minimally invasive surgery? That's a different business plan, perhaps, than if you are a well-established VATS program trying to do minimally invasive surgery for more complex cases. Maybe you think that there are quality benefits. Maybe you think that there's patient satisfaction benefits, but you must understand this at the outset. Then you have to identify surgeon leaders. Yoshi talked about this with TAVR. What's worked for our group and what I've seen work from different groups is a team approach. One pitfall to avoid, and we see this, is assigning the junior partner, the person right out of fellowship, to independently grow a robotic program. You have to remember that that individual is still learning how to do a lobectomy, okay? They need the support on a daily basis from a senior partner. So the senior-junior partner model works very well. You have to have a plan for getting cases onto the robot. This is also a problem not just with junior partners, but if you have a new member of the division growing a robotic program, they have not established the referral patterns, and nobody's given up the cases. You have to make sure that you have the substrate for the program, and you have to make sure that the chief of the division has thought about that. Excuse me. A dedicated OR team works best, in my opinion. I think that you should train your thoracic team to do robotics. Guys, the urology team's not going to cut it. When it comes time to convert to open, let's say you have that PA injury, you ask for the Finichetto or the pledgeted Prolene, you can't have deers in the headlights. Step two is the leadership support. This speaks to comments that Yoshi made as well as Dr. Cerfolio. This has to be done early. And the message here for this conversation is this is not just a tool, but it's a program development. Okay, and that is hopefully going to grow the program. You have to message that you believe there's going to be improved quality. You have to message that you believe there's going to be improved patient satisfaction. And the key here is that this is a long-term investment. The return on this investment takes some time. But data is king, and you have to show your data, and you have to let the leadership, the C-suite, know that it's not just about OR costs, but you're building a program. Do leadership case visits. Okay, we actually invited Dr. Cerfolio to come down and give a grand rounds. Let your leadership team know how programs that do this well are doing it. And don't be afraid to enlist industry's assistance. Listen, they know the market. They've done this before, and they're invested in making your program work, so you can work with them, and I think that that's helpful. If you don't have a multidisciplinary robotics committee, you must have one. And here's the key. It has to be empowered to make decisions on robotic utilization. This is how we got robot time, through the robotic committee. And we established a release time. So if the urologists or the GYNs have open slots within 2 weeks, that goes to me, and you have to establish that. Training is critical, okay? This is how you get quality outcomes. Case observations, I've alluded to that. But when you go and observe a case, like Dr. Cerfolio said earlier, it's not just about how the operation is being done, but what are their processes? What's their equipment? How are they getting their whole program dynamic in place? Simultaneously, you need to be doing the online modules and simulation and wet labs. There are industry courses that will, in many programs, are required for credentialing. The kind heart model is an ex vivo perfused pig lung, which I think is actually a very good way of getting folks some tissue exposure to lobectomy. Proctored cases are required by most programs, and I think are critical. There's no magic number here. I would say somewhere between 3 and 5 proctored days is probably what you're looking for. And you have to identify a proctor who sees things the way you do. You should be in line. You don't want to relearn lobectomy. Make sure your proctor approaches the lobectomy the way you do, and that's your responsibility to figure that out ahead of time. Proper case progression. I can't tell you how, frankly, scary it is when you go and visit a program and the first case they have on a human is a central left upper lobe tumor. You have to do wedges before lobectomies. You have to do benign foregut before esophagectomy, and that needs to be done thoughtfully. I firmly believe in the all-in philosophy. This is like learning a language. When you learn a language, it's immersion. What you can't do is one robotic lobectomy when you reach the lobectomy phase of your learning curve, but then the next 4 are VATS. Then you do one lobe, the next 5 are VATS, because not only are you not getting the muscle memory, but your team's not getting the muscle memory. Okay, and this is a program development as much as it is developing you as a surgeon. One hurdle for many surgeons is thinking about that being away from the bedside. What happens in the emergency situation? So you have to have had the fire drill in a safe, simulated environment. Everybody in that room needs to know how you're going to convert, and that should not be discussed for the first time at the timeout. Once your program is up and running, continuing education is key. I think of this as training like a professional athlete. Watch game tape. When I first started, I watched every one of my videos, and now I still record every video. And there are online video resources. You can go to industry websites, you can go to social media thoracic forums, you can even go to YouTube with the caveat that there's no quality control there, guys. So you have to know whose video you're watching and make sure that you're getting reasonable technique. When it's time to do segmentectomies or time to do more advanced foregut cases, bring a proctor back. That is coaching. That is key. And go back to the lab for simulation. We must all be tracking our data. We use the STS thoracic database. It's easy to pull data from that, but I also track additional data like Dr. Cerfolio was alluding to, case time, docking time, turnover time. Okay? And this is not just for research. It's to ensure that you're having appropriate quality and identifying your learning curve. Make sure that you're not stagnant. But again, be wary of making conclusions too early. For me, I took on robotics early as an attending. My learning curve was about 50 lobectomies, okay? So you don't want to draw conclusions too early. The point of this slide is just to show that I'm constantly comparing myself to standard benchmarks. These are my first 100 anatomic lobectomies compared to Dan O's paper. And again, the numbers are not what I'm trying to point out here, but that I'm looking at what I think are quality metrics, key metrics, and making sure that I'm improving with time. Once your program is up and running, you have to make good on your promise to leadership, right? So marketing. Work with your institutional marketing team. This should be patient and provider-directed efforts. You want to share outcomes. Compelling patient stories are extremely helpful. And we've done several of these test drive events. Industry can bring mobile units out, and it is very impactful to get your referring providers and your patients even on the system. Show them what you're talking about. Show them why you think this is better. Step 7 and the final step is the educational mission. We all believe that we need to be educating the next generation. You have to have your residents and fellows doing the online simulation training. You have to have a clearly defined skill progression. But again, you don't need to reinvent the wheel here. There's papers by Dr. Cerfolio. I'm showing one here on training. Dr. Bora's group has laid out an educational curriculum. So there are people out there willing and ready to help you develop a program and a training curriculum. And it's not just about training your residents and fellows. I think we have a responsibility to train our colleagues, and I think we have a responsibility to train other surgeons nationally, because this really is here to stay. Okay? In conclusion, adoption to robotics really requires a commitment. You have to be willing to take the time to train and get over your learning curve. Even if you are an expert VAT surgeon, you will have a learning curve on the robot. You need proctored cases. You need to secure OR time with leadership and having a robotics committee. And go all in, please. Like learning a language, do this every case if you can. Continuing education is key, and don't reinvent the wheel. Thank you very much, and I'll conclude there.
Excellent talk. Thank you so much, Elliot. I have a question, if no one else does yet.
Yeah.
And when you started to build this program, how did you get leadership buy-in, and how did you continue to get the buy-in to grow? And did you have any hurdles along the way that you could share with us?
Yeah, absolutely. I mean, I think I will admit that we came from a place where our institution believed in robotics. So we were lucky in the sense that we had a developed urology, GYN program, et cetera. That does help. But we really did bring leadership to talks. I was knocking on the doors, engaging them to come to case observations with us. I had the VP of Surgical Services come to a dinner lecture and visit a program with me. We invited Dr. Cerfolio, as I mentioned, to give a talk so that the leadership can actually see, not just hear, but see what a mature program is. And you have to lay out a business plan. You have to be ready to defend why you're doing this, and you have to have looked at your market and see what cases are you not capturing, and make a point for how doing robotic surgery may be a point of distinction and be able to bring in additional cases. Hurdles, we started with 2 robots. We now have 4. Getting additional robots, getting additional time is always a bit of a hurdle. I would encourage everybody to remember that philanthropy is important to support this. But you also, again, it goes back to showing your data, showing that you're doing more surgery, you have more patients coming in the front door. And again, remember, thoracic surgery, guys, we contribute quite a bit to the bottom line. So we have some power.
Excellent. Thank you very much
All
for
right,
your
thank
time.
you.
Okay, our next talk is My Enemy is My Friend, Thoracic Surgery Collaboration with Pulmonary Medicine, Radiation, and Oncology by Jessica Donington from University of Chicago.
Thank you, both of you, for the invite. Appreciate it. Love seeing you guys up here together. My disclosure, probably the more important disclosure for those of you who don't know me well, I do have my own personal frenemy. This is my significant other for many years. But as a prostate doctor, he and I don't share any patients, thank God. Actually, my relation with radiation oncology goes way back before him. This is Quinn Lee. She is the chair of radiation oncology at Stanford. When John Adler, the neurosurgeon, first built the frameless gamma knife known as the cyber knife, Quinn was the lung oncologist, and I was coming on board at Stanford. He reached out to her saying, hey, yeah, we can treat this anywhere. We can go anywhere in the body with this. And Quinn was like, whoa, I'm not ready for this. But she was smart. She saw the potential, but she also saw that she couldn't do this alone, and she wasn't going to do it without surgical buy-in. And she reached out to us. I was just starting, and I got the ability to participate in many early phase 1 trials using SBRT. She then gave her reins over to Bill Liu, the smartest man in the universe. He's like teaching electrons to do stuff now. And he has always been a really good collaborator. And through them, I have met all of these people. This is really the who's who of thoracic radiation oncology in the world. I know these people on a first name basis, and they are always willing to reach out and work with me, and they have been very useful in my career. I recently had to do some work for an application and had to look at my most influential publications. So this is my Scopus. These are my most quoted and cited articles. And when I look at it, over half of my top 20 articles are direct collaborations with people outside of thoracic surgery. This one's with anesthesia, that one's with medical oncology. But the reality is the overwhelming majority are with radiation oncologists and pulmonary medicine doctors. So they have meant a lot in my career, and I believe the collaboration is really important. It's led to many important articles and journals which I may not have been able to get into on my own. But I do think that collaboration goes a lot further than my H-index, and there are more reasons to do that. And maybe the most important reason we should collaborate with our peers is that we share a common enemy. Let's face it, we are lung cancer doctors, and we have not won this battle. Let's face it, our part of lung cancer is we really dominate with the treatment of early stage lung cancer, but with cure rates that range from 52 to 92%, this is not a battle we have won, and I don't believe it's a battle that as thoracic surgeons we can win on our own. These are the things we do to treat people who have lung cancer. We diagnose, we stage, we do definitive management. But the reality is we have lots of peers that kind of share in this, and the lines between what part they do and what part we do are very unclear. So collaboration is not just useful, it's a necessity. So why collaborate rather than compete? Because collaborative environments are more productive. Let's face it. It's also, we are in a technology-driven field, and survival of the fittest is a real thing. To stay up to date, you need to learn from others who have different skill sets. And I really believe that no one of us is as smart as all of us. Why should others want to collaborate with us? Why should a radiation oncologist with like 8 PhDs and all that care what I think? Well, one reason is that we are the experts on the treatment of early stage non-small cell lung cancer, and therefore your voice and your opinion really has value. Our input is what really can take some of these technologies and move them forward. Many of them stay on the fringe until they get buy-in from thoracic surgery. I also think we need to recognize that there are fewer and fewer patients who will be treated by general thoracic surgeons alone. So it brings up the concept of competitive collaboration. And within business, competitive collaboration is something that's been around for a very long time because they get it, that eventually competition wears thin and a collaborative approach makes more sense. You'll hear a lot about kind of red and green zones. I love this thing about the chickens that there are, if you have a whole group of chickens, they all lay eggs at different rates, and there's usually one chicken that outperforms all the others. But when they tried to breed those chickens and just get high output chickens, this is what they got. Nearly dead chickens, because it turns out the high output chickens were pecking the other chickens. And so if you actually look at the ones that you breed against, then you get these nice, fat, healthy chickens, and you increase your egg rates by like 5% or 5 times. So collaborative environments are usually more productive. And these are some of the red zone and green zone things that people talk about. And there's this really strong belief that a green zone is a more productive zone. I also love this hard versus soft power from Joseph Nye. I did have some surgeon pictures on here, but I took them off because I'm a believer in soft power. But hard power works through threat and force, while soft power works through influence, attraction, and persuasion. I also had some political voices I put on here too, but I took those off. But the reality is if you only work through hard force and you're only threatening to people, there will be important conversations that you are not included in. And if you're not at the table, you can't help drive those decisions. This is from Microsoft, but it really talks about what we would like to do within our lung cancer programs. Connect, communicate, collaborate, co-create, and build a sustainable competitive advantage over other programs in the area and over our survivals in this disease. So what are the keys to successful collaboration? Well, I think there has to be a collective responsibility. You can't just bring them in name. You have to share risk and the process. There needs to be engagement from leaders because we've talked about this, that sometimes all working together doesn't generate the most RVUs. You may need a neutral intermediary because you may not always get along, but probably most importantly, you need a long-term outlook. You need to be collaboration ready. You have to be ready for the fact that the ideas from others might work. You need to be willing to say maybe. You need to be open for change. And you're going to recognize that your survival and success is not at the cost of the other technologies and other collaborators. You need to divide and conquer. You can't do all the work if you're building a multidisciplinary program with many outlooks and many techniques. You need to trust each other and rely on the strengths. And you need to recognize that no one of us has all the resources to reach our common goal. And a little bit, you have to have a smart leader and collaborator. We're very fortunate at Stanford to have leadership at there who really believed that SBRT was going to be important and that they were going to take care of us till we got through some of these painful early trials. And they provided us guidance at times when we didn't know what the right answers was. You need to be a little egoless and admit, like for me, that surgery wasn't the answer for every patient. I needed to be willing to admit that that 80-year-old whose PFTs were kind of okay, but he walked with a cane, and yeah, I can get him through, but that maybe getting him through wasn't good enough. And that if the risk was more than standard, I needed to think about another way to do it. And you need to be really not defensive in saying that what I do may not always be the best thing. So, oh goodness gracious, I can't spell. Disruptive technology, good God. Sorry. So what do we do when their new technology really encroaches on what's our bread and butter? And we've seen this before in lung cancer, SBRT, RFA, EBUS for, who does mediastinoscopy anymore? None of us, hardly. Navigational bronchoscopy, even pleurexies and lytic therapy for effusions, these are our bread and butter. But, we have to adopt, we have to move forward. The reality is we can't hold back technology. What you want to be able to do is guide how they get introduced and used, not only at your institution, but maybe nationally. But this requires a collegial and collaborative environment. You can't wait till they're already doing the technology and then say, hey, you can't do that without me. It has to happen in the beginning, and I really believe that. And you really have to work hard to be viewed as an asset and not a hindrance to it moving forward. I think it's really important to take a programmatic approach. We've just heard about this from Yoshi, and what a program means when you're dealing with a new technology. It really allows you to work, if you're working together, you get broader outreach, you go to surgeons, you go to radiation oncologists, you get to talk to everybody. I think it's more appealing when dealing with a new technology to be within a program, and as a surgeon, you really bring a lot of validation to the safety and quality of these new technologies. I also found that it really did help build my surgical practice. At Stanford, when we were the only ones offering SBRT, we saw so many patients who came in for SBRT and we operated on them because they were perfectly good surgical candidates, just no one had thought about it. So I think it really can build your surgical practice, and you need to know that. I think we do need to think a little bit about endoscopic ablative therapies. In lung cancer, this is a little new paradigm for us. So unlike SBRT, the interventional pulmonologists have become the gatekeepers for a lot of nodule and cancer detection, and now they're going to have the ability to both diagnose and treat. This is a little bit of what interventional cardiologists have been for years, and I think if we don't want to get back in that situation where our cardiac colleagues were, we really need to be in on this on the ground floor. You need to be reaching out to your pulmonologist now to say, how are we going to do this? How are we going to run the trial? How can I help you? So that you understand how they're bringing it in. I also believe we should collaborate on an organizational level. These are all of the organizations that I have worked with in the last year on guidelines, on speeches, on different things. I think education, I teach their fellows. This is something that we all need to do so that we are not something that they are afraid to talk to and reach out to. Does collaboration work? Sure, we have guidelines that are very multidisciplinary, but maybe the most important thing we do right now in terms of collaboration are the Stand Up to Cancer Dream Teams. These are specifically designed to take competitors from multidisciplinary specialties and put them together to solve the bigger problem. And to date, these have been very successful, very productive, and moving the research forward. So I think competitive collaboration is an important business strategy, and it's an important way to build market share for your program. You have to remember that your voice is important in non-small cell lung cancer. New technologies are going to move forward with or without you, but if you can engage early, you can help guide appropriate use at your institution. Thank you.
Thank you, Jessica. Excellent talk. Any questions in the audience?
interventional pulmonologist who led with the statement that my main goal is to keep the thoracic surgeon out of the airway. And I had to give the next presentation.
Except when they have a giant tumor and now they're bleeding and then
Well,
they're calling us
exactly.
in the middle of the night.
So the question is, and now at our institution we are, and I'm going to be stereotypical here and act like a surgeon, say I'm hearing the oxymoron medical thoracoscopy. And what do we do, how do we handle these situations where there are procedures where we can both do and both want to do? And yes, we can collaborate, but really there's RVUs here to be fought for. How do you handle that potentially contentious situation?
It's very contentious. This is where you have to be friends. You have got to get together and say, you know, we need to support each other and we need to set guidelines. I know exactly what you're saying. I have one IP guy who thinks he's the world's best pleuroscopist. And you just kind of look at him and you're like, really? But I set very clear guidelines. I say, hey, if you want my backup, if you want to know I'm here from you, this is what you are allowed to do. And I also kind of set number levels with his chief. And I say, hey, you know, we're letting you kind of do this when we know we can do it more efficiently because he likes it and he wants to build a practice. But we can do all of the EBUS ourselves. We're happy to do these. So you're right, we are sharing. But I think this is more about thinking about what's the best for your program, and I keep hoping he'll outgrow pleuroscopy.
3 comments. First of all, there is no greater collaborator in the world than Dr. Jessica Donington. So that slide that she showed about softer is better, about the red chicken, I unfortunately was the red chicken for a long time, and I had it wrong.
It wasn't your picture, sir. It
Well,
wasn't.
it could have been. So, and I think it's really hard to learn because as an athlete and as a student, as a surgeon, you want to be a best, you want to be the pace setter. That always fails. That's such a hard lesson to learn. You helped me learn it, and there's no better collaborator cross specialty than you. So I congratulate you for that, and I love that slide of the chicken. I'm going to use it. That's the most important point. The second one is about Ion. So we bought Ion, which is one of the robotic airway, but we have both our interventional pulmonologist and us using it. We started off using it in the OR, 10 cases, they're using it, and it is about getting buy-in that you ain't gonna make money with this, you're gonna lose money. You gotta come to an administrator like me and I say, I get it. It's about building something bigger and about setting the pathway to treating lung cancer, and it'll get volume. So you have to have vision in the C-suite. It's up to you to make sure they have that vision. Keep knocking on their door and invite them in the OR if they're not MDs. That's a great thing that Elliot did, brought him in the OR. Then they'll realize the pressure you're under, how hard you work, and why you should make more money than them. I'm going to say it again. Why you, the doctor, should make more money than the administrator.
A comment and then a question. So one of the things that Peter Pisters, our new president, said, which I thought was really insightful, is we as a profession, as physicians, start out in high school being very competitive, right? The goal is to get the best grade so you can get into the best university, right? And we get into university, and we're again very competitive because we want to get into the best medical school. And in medical school, we compete against each other to get the best scores so we can get the best residency. And then we continue that with the best fellowship. And then when we get out, we're told to work together. It is not a skill that we have practiced or tried to cultivate for 20-odd years of training. But you're absolutely right, if we're going to move forward, and it's not just us, the pulmonologist did that too, and the radiation therapist did that too. So the question for you, I guess, is in institutions like yours, where it's high volume centers with lung cancer, you can sometimes assuage, as Yoshi said, the issues surrounding RVU and fee-for-service based models. But the vast majority of lung cancer in America is cared for in smaller centers that don't have that volume, where the surgeon is trying to do multiple things, not just lung cancer. How is that going to work?
I think it's hard, but I do think it gets down to some things at the end that we are all, you know, as a general surgeon, if I'm one person in a hospital, I'm still going to be more efficient if I have a pulmonary colleague who can take care of many of the small procedures which aren't going to generate as many RVUs, and it can feed me cases. So I still think, even when it's on a very small level, I still think that it's useful, and that and you're never going to be able to collaborate with everybody, and there will always be personalities that don't work. But if you can find that one or two people, I think then it makes perfect. I still think it makes sense.
Thank you, Dr. Donaldson. We're going to change gears a little bit and talk on the cardiac surgery side. How can my enemy is my friend, cardiac surgery needs cardiology, and vice versa. And this will be presented by Dr. Robert Guyton.
Thank you. I appreciate the opportunity to present this topic. Disclosure's most important. I was on the ACC board for 9 years, and I do like cardiologists. Are we friends or enemies? Do you play well in the sandbox together? Secondly, do you share your toys? And then third, friends or enemies? In the workplace, do we share challenges, joys, and sorrows? I'm going to show 4 cases quickly that show how we take each other's tools, talents, and use the interventional cardiologist and the imaging and the surgical skills to create hybrid procedures that use the skills of all of these areas to create a patient-specific and pathology-specific procedure for hybrid repair of post-infarct VSDs. This first is a small apical VSD, 7 days after the onset of chest pain, clinically stable, but you see the VSD at the apex. 22 days after the infarction, because he was stable that long, we wanted his tissues to firm up. Went to the OR, did a subcostal incision for access to the apex. We learned this from doing our transplants and our VADs, that we can access the apex without opening the chest. Micropuncture wire, then a sheath placed in, then an Amplatzer septal occluder advanced through the sheath, deploying the left ventricular side in the LV, and then exteriorizing the right ventricular side, pulling it over against the septum and closing the VSD, and then pushing the right ventricular free wall against the septum, closing the VSD further. This is the operative picture. This patient had no residual shunt, went home in a week. 4 months later, a small residual VSD, playing golf. The next patient, a mid-septal VSD, admitted 5 days after infarct, a new murmur 7 days after infarct, came to Emory. Again, we watched him for 5 more days, but then his creatinine started to rise, pulmonary pressure rose, taken to the operating room 12 days after infarct. Again, a subcostal incision, but now in order to get higher up on the ventricle, we needed to do a lower sternotomy, teed off at the 4th interspace with great exposure of the RV free wall. This is the VSD in the mid-septum. This is the injection at the time of the hour. You see how big the RV is and how the RV is starting to fail. This patient also had an Amplatzer device, but this time we put both wings of the Amplatzer device in the LV, and then we pulled it down against the septum, as you see here, and then the ventriculogram showing that this essentially closed the VSD. This was probably our most successful of this group, and this patient went home in 5 days, went back to Florida 5 days after the procedure. This patient is the problem patient, a large early VSD, probably ruptured on day 2 or 3. Another hospital tried to open the LAD, had to put an Impella in for cardiogenic shock. They put an Impella 2.5 in the femoral artery, had expected leg ischemia, transferred to Emory in shock liver, anuric, hypoxic, and an ischemic leg. We worked on her for 3 days and then took her to the operating room. This is the picture of the really quite large VSD at the apex. This Amplatzer device, again, put in through a subcostal incision, pulled over against the septum, but this time you can see that the device didn't really sit well against the septum. It was bouncing up and down. So in this procedure, we did something different. This is the right ventricular free wall platform. We put a wire in across the device, and we're able to put a tether in. Let's see, I'm not advancing. Put a tether in, and we were able to put another tether in to pull down the side of that Amplatzer device. So from this, we learned that we could put an additional tether in. We took the shunt from about a 2-to-1 shunt down to a 1.3-to-1 shunt. She slowly improved, left the OR with a 1.3-to-1 shunt, but the Impella still in. Improved over the next 2 days. On postoperative day 3, the Impella was removed, fasciotomies in the legs, but the next day, the tissues tore loose, the device pulled through, and she developed a huge shunt and died. The fourth case is one of the harder VSDs, a big inferior VSD, which is certainly a different animal than the anterior VSDs. This patient, 3-day history of chest pain and inferior MI cath, showed a total right. The patient had progressive congestive failure, came to us about 5 days after the infarct. Creatinine had risen to 2.3, large inferior VSD. The patient was in shock. Our interventional colleagues did a transcaval placement of an Impella 5.0. The QP to QS went from 2.9 down to 1.7. The SVC O2 saturation initially was 34, essentially a dying patient with lactate rising. SVOC sat went up to 47. The patient stabilized. This is a transcaval technique showing the wire going up the femoral vein, crossing over to the aorta, a stiff wire put in, and then a big sheath across the aorta. And then when it's taken out, it's closed with a closure device. This patient improved over the next 7 days. Creatinine came down from 2.3 to 1.4. He was not intubated. He was awake, talking to us. But then on day 12 after the infarct, he suddenly deteriorated. This was on a Friday evening, of course. And then the creatinine rose to 2.7, stopped making urine, lactate up to 10. And the echo showed blood in the pericardium. We thought maybe he perforated. At 3 a.m., with the cardiology fellow, I tapped his pericardium. The tamponade got better. We took him to the OR on Saturday the next day. And I wasn't on call. The interventional cardiologist wasn't on call, but we both were invested in the care of this patient. And we took him to the OR on Saturday morning. This is the VSD. As you can see, it's huge. And then this is after the repair. And you can see the patch here. And then this is the removal. We had hemorrhagic pericarditis. We couldn't leave the Impella in. We couldn't leave the patient on heparin, so we took the sheath out. Interventional cardiologist in the hybrid room put the plug in. You see the plug here. And then afterwards, we had a aorta to IVC fistula, which is fairly common in these procedures. These close after a couple of days, but here we have this fistula. And then the patient comes back to the OR. The tissues at operation were firm. I was able to put my sutures in. That additional week that we had was very important. There was no postoperative shunt. He had a slow recovery and discharged on postoperative day 28, making over 1 liter of urine, but still on some dialysis. So if we want to stay in the race, we must be friends, not enemies. We just can't do it alone in this era. So this is an example of taking the skills of both teams, working together, using what they have, using what we have, and making it happen for the patients. Thank you.
Dr. Guy, quick question. So, sometimes friends get in fights, and sometimes friends think they can do things better than their counterpart, their best friend even. So how do you reconcile the difference when your friend thinks that he or she can maybe do that mitral valve repair better than you can?
This comes back to spending your 10,000 hours together, which happens pretty fast when you've got combo clinics twice a week and you're in the cath lab together 2 days a week and you're in the OR by yourself 1 day a week. And that's kind of where we're moving, is the time we spend together is now much greater than the time we spend apart. And we're really looking at the patients in the combo clinics together, and I say, this patient, I could get this patient through the operation, but they're never going to recover their robust vitality because the operation is just going to take too much out of them. Because they're 85 years old, nothing like heart surgery to bring out your age. And this is something that you can probably do better. And then at the other hand, they're looking at this 55-year-old patient who's a pretty good patient for a transcatheter aortic valve. But they say, you know, this patient's got 45 years to go, and I think the best thing would be to put in a nice-sized bioprosthetic valve as the first step, and then maybe 1 or 2 transcatheter valves down the road. And that collaboration in the clinic diffuses the conflict, and the time spent together, I think, is the key. And so that's my opinion about that.
Thank you, Dr. Guyton. We're going to change gears a little bit and start looking to the future. The next talk will be by Dr. Stephen Bowling, and he's going to talk about innovation. To stay relevant, we must innovate as surgeons. Dr. Bowling.
Good morning. So this is a picture of 2 cardiac surgeons talking one day, and they look up and see that giant meteorite, and they go, huh, what's with that? So I'm going to talk about innovation as a cardiac surgeon. And innovate, and I operate 24/7. I barely have time to eat. But innovation, innovatio, the Latin word new idea, and innovation is really evolving a new idea from nothing to something, and we know that evolution takes time. And so to innovate, we as surgeons have to set aside time to think and observe, time to learn the skills of innovation, time to work hard at it. I have spent decades to be a good cardiac surgeon, and somehow we all think that innovation is just something we can do, that it'll just come to us. That is not true. Here is you running your first marathon, right? You didn't do very well. Here is you, you've put years into it, you just broke 2 hours and set a world record. Okay, that's not you, that's Eliud Kipchoge, and he put a lot of time in it. And so innovation is another skill set that we have to develop. It is different than doing a mitral valve. So what is a new idea, that innovation? Woo, we think it's some intangible product of the mind. Woo, it's not. You know, intellectual property is very tangible. It's real, it has worth, it's protected by law, it's a thing. You already have a new idea. If you've ever thought to yourself, if you've ever said, I can do that better, what we really need is a blah, blah, blah. Why isn't there a yeah, blah, blah? If you've ever whined in the operating room, you have a new idea and you can innovate. But be mindful of it. Don't just be whiny, be mindful. And think about it based on your research, your clinical practice, everything that you see. Here's a tip. Don't be completely satisfied. Something could be better. Where do ideas come from? We hear this phrase, outside the box. That is ridiculous. What is the chance of one of us walking down the street and suddenly thinking, oh my gosh, I have a great idea about cold fusion energy sources? That's not going to happen for me. Think inside your box. That's your skill set. I'm going to think about cardiac stuff because that's my skill set. So once you have your idea, write your idea down. But an idea scribbled on a napkin is worth less than a napkin because now it's a used napkin. And you're not going to go to some company and say, give me $1 million for this napkin. That's not going to happen. This is the innovation plan that you should always use. Start up, cash in, sell out, bro down. No, that's not what you do. You have to evolve the idea. An evolution of something involves a change agent. And that involves hard work, passion, expertise, money, and then more hard work. Cardiac surgeons thrive on hard work. We're really good at that. Once you have an idea and you're the change agent, protect the idea. A CDA, if you talk to anyone about your idea with a CDA, I will steal it from you. So if you talk to anyone, get a CDA. And also patent, patent, patent. The United States is the last country in the world to go to first to file. It doesn't matter if you wrote it down in 1964 and put it on a napkin, it's first to file. The famous cardiac surgeon, Joseph Stalin, said, trust, but verify. So protect your idea, but also protect yourself. Learn the conflict of interest policy and so on. At your academic institution, they vary from place to place. There's no standard one. And think about it this way. Can you explain what you're doing in 10 words to your mother or 5 words in a headline Heart surgeon does bad thing. Do the right thing. And time your idea. You've protected it, you're evolving it, but time it. Predict 5 or 10 years ahead. Not 1 year, no one cares. I just had a great idea for a 7-lumen swan. We already have a 6-lumen swan. I just invented a 7-lumen swan. No one cares. They're going to have that in a year, and it's useless. Also, not 100 years from now, no one really cares because we're going to have submolecular atomic microgene splicing nanobots take care of everything, or I don't know. Why is founder a bad word? I thought this thing up. I'm the founder of this thing. Okay, a founder is fixated on a vision, overrate your own capabilities, fails to delegate, micromanages everything. That is perfect for a cardiac surgeon. That is our skill set. But it is not perfect for idea evolution. It is not innovative. So you need an innovation team. Everyone in this room is going to be shocked, but I'm going to tell you, you are not the best at everything. That's why cardiac surgeons who can afford small planes fly them directly into mountains and die. Get a super smart, motivated team. Make them have complementary expertise. Don't get together with 4 other heart surgeons. That's not going to be good. Make them very domain specific, and also make them nice. You're going to spend a lot of time with these people. Okay, so you have your dream team now. There's you have your good idea, you have the dream, you have an engineer maybe, he can prototype and test, you have a manager, she's going to lead you and execute the plan because you didn't go to business school. Get a lawyer, you need a real business lawyer and something like that. Who pays for this? That sounds expensive. Early money comes from angels when you innovate, or friends and family. Your institution may have an innovation fund because they realize you can make money from this. NIH, SBIR, STTTR, be careful of self-funding. As CT surgeons, we have a lot of money and we can lose it all on a bad idea. The next thing we go to is venture capital. And you can see here's a venture capitalist talking to an innovator. With your idea and my nothing, we could be rich. These guys are rip-off artists. No, they're not. This is what they do. They're much better at it than us. Here's the question you have to ask. Does a VC care about your innovation? And here's the answer, and it's always true. Will it make money? That's it. That's what they do. We gauge ourselves by patient outcome, mortality, morbidity, and so on. They gauge themselves. The way they keep score is how much money do they make. And we saw the other day, I was one of the Shark Tank judges. You have to show me the management, your market, the size, the impact, your technology, where the other guy's technology, and so on like that. Forget all about that. It's the deal. Do the economics allow everyone to profit? And the answer is they want a 10-to-1 return because 10 deals that they turn in, 9 will absolutely flop. So if you give me $5 million, I have to think we're going to make $50 million on that just to break even. Innovation is not research. Industry is very different than academics. Investors are wary about MD, PhDs. We don't think the same way. We don't have the same skill set. Publication is public. So if you publish something, it's out there. I will steal it from you. Now's a good part about innovation. Make it work. Iterate, test, reiterate, retest, and fail super fast. And I'm going to sum up by talking about how we do that. Innovation failure is in all of us. Trained coal stokers, they don't exist anymore. Did they not innovate? Milkman, think about when was the last time you saw a milkman driving in your neighborhood? Factory worker, cardiac surgeon, are we going to evolutionarily fail? No, surgeons are device innovator cowboy kings. We've thought up a lot of stuff really well. And almost always we take something that we have learned over decades, a technique, and from that we'll develop a technology, and then the cardiologists or the pulmonary guys will steal it from us and we'll drop the technique. This is how we evolve. Think of this, coronary bypass, look at that. The best way to treat that is a mammary to the LAD. However, everyone's going to get a PTCA because innovation says if it's easier and it works pretty much the same, it will displace the technique. Now, wait a minute. Young guys in cardiac say, what? Coronary bypass is best. Syntax score, you idiots. No, you got to bypass them. Sorry, Tom. Grunsik says, you're out, man. You are out. We have to be aware of the technology complexity paradox. Look at the left, a manual transmission. Look at the right, technology, way more complex behind the scenes. That manual transmission is just a stick that lifts stuff. Automatic transmission, super complex, but to you and me, it's just D. That's it. And we all drive an automatic transmission. It's got to be easier to the user. There's a telephone switchboard 100 years ago. 75 people trying to get a call through. To the right is my actual granddaughter calling me on an iPhone. Well, that iPhone's way more complex, but to the user, it's much easier. The robot, is it easier to the user? It doesn't look easy to me. When was the first mitral robot done? 27 years ago. Have we adopted it? No, because it's not easier, and it'll never happen. That's why you don't have a robot maid at home, and I didn't fly over here from my hotel on a robot jetpack. It's not easy. It doesn't work. That's innovation failure 1. This, however, is easier and works the same, looks the same, no more surgical AVR. The mitral valve, my field, is super complex, and to think that we can take a valve and turn it upside down and jam it in there, that's not going to happen. So we've had TMVR innovation failure to this date because they're big, they're distorted, we go up through the apex, and that's why the mitral field looks still like this, with innovation going in all directions. And that's okay, because we're going to come up with transcatheter cords and rings and clips and things. I don't even know what they are. That's okay. It has to be easy, but if it doesn't work, that's another failure. And think of this, indirect coronary sinus angioplasty, not thought up by a surgeon. Every other thing on that list was thought up by a surgeon. This wasn't. Any surgeon could look at that and say, that's not going to work because the coronary sinus is nowhere near the mitral annulus. And this is what happened. The graveyard of coronary sinus devices with a bunch of money going down the toilet. Evolution is always fair in any field, and it's certainly fair in innovation, but it's never fair to any individual. Innovation. I was being a heart surgeon for 40 years. So these are the 2 things that I do the same. Heparin at one end, protamine at the other. That's it. Every other thing I do is different. We have changed everything I do except those 2 things. So obviously, we innovate to keep our field alive. These are the 4 P's that I think of. People, plan, plenty of time, and plenty of money. You get that, and we as CT surgeons can innovate. So, in conclusion, you already have an idea. It takes forever to be an overnight success. Enjoy it. Thanks.
So, Dr. Bowen, real quick question. So the 4 Ps, I want to focus on the last 2 Ps, time and money. Can you give us an idea of exactly how much time one can expect to be able to innovate and bring a device or product into market, and realistically how much money it'll take of your own pocket to make this happen?
It depends, on the device and so on like that, but I would say from years scribbling it on a napkin to first in man is somewhere between 5 and 10 years, and then from that to widespread, use is 5 to 10 years. So you may be talking a 20-year course of things. The amount of money that's spent, you can imagine, to develop a product may cost you $20 to $50 million. To run an IDE device trial is $25 or $30 million. So you're talking upwards to $100 million to get a device on the market. So it's been estimated that the indirect coronary sinus angioplasty kind of concept has dumped almost $2.5 billion lost because of that. So that is the amount of money we're talking that it takes to develop a device. That one didn't even work.
I don't have that sort of money, so I guess you rely on your angel investors and your friends and families to kind of help you get out of the gate. How do you do that specifically?
So you have to know, and venture capital can come in early, but again, venture capitalists are specialists. There's guys who know about sensors. There's guys who know about cardiac devices. There's people who know about thoracic devices. So you have to get matched up, and it is really like a marriage. Get a prenuptial agreement and get the right partner, but they're out there.
Thank you so much. Any other questions from the audience? Thank you, Dr. Bowling.
Thanks.
So in the spirit of thinking about the future, which is important for our future, is what are the societies doing to make sure that we stay relevant in the future? This talk will be given by Dr. Joseph Bavaria.
Thanks, guys. So, Tom, this is an interesting one. Behind the scenes, I think that's the key concept, which really made me think about this a little bit. These are my disclosures, and a couple of them are the TBT registry chair and the writer of some of the TAVR stuff that's been going on at the ACC and the STS, as well as our investigations. So the professional society's role, which was part of the talk, but really what's going on behind the scenes. So let's talk a little bit about that. So the first one is, what are we doing to kind of keep us relevant? That was the charge. So in the general research or clinical and the annual meetings program. So for example, I'm just going to give you some examples of what we, the societies, are doing to keep us relevant. So here's a trial from the CT Surgery Network, and that was really, really important. This trial was done by the CT Surgery Network, and then it was presented at the AATS. This was the result in mortality, which was not significant. So the mortality is the same as in functional MR with repair replacement. But the amount of MR was massively reduced with mitral valve replacement. So this was, kind of a striking trial in many, many ways. I'm not going to go into the trial, but the bottom line is that from the standpoint of what we're trying to do behind the scenes is that this trial was presented at the AATS meeting. The data was rapidly disseminated with practice changes measured by an increase in mitral valve replacement for functional MR as captured in the STS database. So the behind the scenes work to get this trial done and then to have it disseminated and then have a measurable action was part of what the societies are doing and what they're doing sometimes behind the scenes, although in this particular case, with the education component, it's not really totally behind the scenes. It is a little bit behind the scenes in the sense that the program committees do make the programs of the major annual meetings with you in mind and what they're trying to do to keep you relevant. So what about new technology, new stuff, and the whole flow of information? Well, we have a whole bunch of stuff out there that's new in our space. Some things at the aortic side, the valvular side, structural side, almost everything. And here's an example of some really new, wild stuff that we never thought would be happening, which is primary endovascular repair of type A dissection. And this is the second one of these done, which was not at our place, but the first one was done at the University of Michigan. So these are very, very new things. And this is an example of some of the stuff that Steve was talking about, which is functional MR, and whether we have transcatheter mitral valve replacement for this. All the trials demand a multidisciplinary team, and the best results ensue if you have a multidisciplinary team. So these examples of new technology. And here's an example of one of the valves that was placed transeptally for functional MR, and the results are pretty good. It's not that simple though, as was just said. But the point of this slide, or this talk, is that all these new technologies, new procedures will be presented at our society's annual meetings. They will be discussed and analyzed at the meetings, and they're published and editorialized in our society's journals. The communication in a sophisticated, not a lay language, will be done by the societies, and then the subject of recurrent educational programs, videos, and subsequent data and analytics. In other words, they'll take it to the next level. So it's kind of a virtuous circle. Now that stuff's not really totally behind the scenes, which is what the talk was about. Now some of it is behind the scenes. So when we get new data and new concepts and new things out there, we end up doing taking those areas and putting them into our databases. So here's just an example of that. This is the TBT registry. We have a whole bunch of new stuff coming down the pike: cerebral protection, fracturing of sewing rings, etc., catheter-based electrosurgical techniques to lacerate leaflets. That's the basilica procedure. Vascular access, transcable. You just saw a transcable approach a couple of talks ago. All these things are new. And eventually, and actually fairly quickly, they get into the databases so that we can analyze them. And this allows us to do things that can keep our constituents, relevant. So as soon as the societies, in this case the STS, collect enough registry data on new technology, we report on it through the R&P process, through the research and publication process, with both raw outcomes as well as analytics, which is comparative outcomes. So utilizing the database to publish big data results. I've said this before, science tells us what we can do, guidelines tell us what we should do, registries what we're actually doing. So our registries are pretty important. So real world clinical outcomes, here's an example. So we take this is behind the scenes. It was apparent just last year in the TAVR and transcatheter mitral valve space and other structural spaces that we were going through a very significant time with the government and payment and organization of medicine in this area. And so we felt that this was the STS and ACC, that we would start to accumulate some data to inform CMS and others about what the heck's going on. And so this is a look at transcatheter valve replacement, approximately 27% risk reduction, high volume versus low volume centers. This is a whole access issue with the government. And this kind of ACC, STS, society registry activity is then used to inform CMS and insurance company policies regarding heart team requirements, which was talked about earlier, quality mandates, billing mandates, institutional suggestions. All of this is really, really helping to keep surgeons relevant in this area. And another example is this one. Here's a slide from the registry showing basically no pacemaker differences in TAVR over the last 6 years. Despite what all the prospective randomized trials are looking at, this is actually 250,000 cases. So what happens? The societies, this is a little bit behind the scenes. We have that data, we know that data, and then we're going to wrap around that data. Okay, how do you wrap around that data? Well, the first thing you do is, you publish a paper from it saying, look, early pacemaker implantation is a common complication following TAVR. It is associated with higher mortality and a composite of mortality and heart failure admission at 1 year. Well, this is pretty significant. This has major significance about the relevance of cardiac surgeons in this space. And it's a little bit sophisticated. It's a little bit working in multiple domains. And here's another one. This is just from the registry, and this was actually progressed and proposed by the societies, and was presented at the TCT. And basically, what it showed is that there's a lot of PPM in TAVRs. This is just an example, another example of what's going on behind the scenes, which then has a major impact on the relevance of cardiac surgeons in the space. So an additional word about research is that some of the really big questions that we have to answer, like PCI CABG, like TAVR-SAVR, like mitral valve, the whole mitral valve cascade, which is quite substantial. A lot of these can be answered only with very big data and linked databases. And so we're going to be looking forward to some of this significant research. Member surveys. We do member surveys. These are a little bit behind the scenes as well. And we found, for example, we did a member survey at the STS with TAVR surgeons. We got a pretty good response. Now, what we found out that surgeons actually do, because of the mandates that were originated in the 2012 NCD, which was another behind-the-scenes effort, that we have actually, compared to everybody else in the world, surgeons are doing a lot in TAVR. And even more important, that cardiac surgical and combined collaborative programs basically administrate TAVR programs in the United States. This is really important. So what do we do with this data? That's the example. The data corroborates the fact that TAVR programs are usually jointly administered in the United States, and this is called the administrative heart team. And what was the member benefit? Well, this data was then taken to the companies, to the manufacturers, to CMS, to FDA, and it allowed us to kind of make our case that we need to be a collaborative team in this space. So inter-society collaboration vis-a-vis government relations. This is a little bit of a black box, as everybody knows. It's a little ugly. And, but as Donald Rumsfeld said, democracy is a little bit ugly. So the STS, in 2012, the two societies worked together, collaborated, and came up with a radical and revolutionary approach to a brand new technology and how it's administered and done. And this was the TAVR NCD. The entire approach of CMS and FDA was a heart team in collaboration of organized CV medicine and surgery to create the TVT and quality metrics, among other things. And then the multi-society document informed the government And this is when we got the multidisciplinary team codified and all of the surgeon and the cardiologist doing these procedures together. This is the very first time in history it's ever been done. And this is a typical heart team. This is our heart team for TAVR team. Now, again, behind the scenes, it was time for an update. Well, how did this happen? How did we get an update? We got an update because of a phone call between two people. The phone call between the president of the ACC and the president of the STS. Okay, and that happened, and that was behind the scenes, and then a whole thing's cascaded because of that. And then we ended up with the society documents. This informed CMS, and then CMS had a decision memo with an NCD that was fairly favorable to our specialty. This is behind the scenes stuff that I suppose Tom wanted me to talk about. So the new NCD opens up TAVR access, which is a good thing in many respects, but maintains a lot of good things. The heart team, the surgeon IC operator teams, institutional requirements, so it gives the physicians a chance to say, hey, you got to do this to your administrators because it's in the law. And we did that on purpose. TVT registry is mandated and highly suggested quality composites, which are best for our patients. And the ABTS is now on board and taking this to the next level. So the charge of this talk, behind the scenes, what are our societies doing to keep us relevant? Peer education, annual meetings, societies, specialty conferences, mechanical cyst, et cetera, critical care, structural heart, TEVAR, ECMO. Not all of this is necessary behind the scenes, but much is planned and orchestrated via the program committees behind the scenes. Research, don't undervalue this aspect. This is actually more important than most people think. Linked registry databases, huge numbers, advanced statistics, like the Cabbage PCI, New England Journal of Medicine type of articles. This is all done and is really good for our specialty and good for you, and is done by the societies somewhat behind the scenes in the beginning. Leveraging database outcomes to national practice, STS alliances with other organizations such as ACC and AATS, and direct Washington initiatives have basically caused a lot of wins in what we do. Just a couple of them, ECMO, as well as all the TAVR and transcatheter mitral NCDs. So thank you very much.
Thank you, Dr. Bavaria. The floor is open for any questions. Dr. Bavaria, you talked a little about the STS role with the government, but it's still a little bit of a black box to me. And can you elaborate on logistically what happens when the STS reaches out to the government, mainly CMS or other governing bodies?
Well, you know, Bismarck said that, you know, making laws and making sausage is, you know, is something that you don't really want to take a look at. And you don't really want to know how it's made. So the fact of the matter is Washington is an incredibly Byzantine and chaotic place, but it's the way democracy works, and you got to be in there. And it's very, very complicated stuff, and it's not for the faint of heart. And so the STS has taken this upon itself to do this for our specialty, and a lot of other organizations do it as well. It's the nature of the beast. You have to do it. If you're not at the table, you're going to be, you know, eating for lunch. So this is kind of how it's done, and we've had some great successes with some of the things we've done.
It's almost essential because the government or CMS are the ones that are going to be creating the guidelines for any cases for use. So it's important for us to stay involved and have an open line of
connected. Yeah,
communication.
it's about long-term relationships too with the government.
And can you elaborate a little bit about behind-the-scenes collaboration with other specialties? And you hinted at it a little bit, but I suspect that's more complicated as well because we have our frenemies out there, and sometimes our frenemies, you know, don't get along. So
it's true, and sometimes the chasm is too great to jump. Like what happened with PCI and Cabbage when we linked our databases, and we got a great New England Journal of Medicine article out that was but it ended up being a little bit positive for Cabbage. So then ACC shut it down because they were getting a lot of heat from their interventional cardiologists. So, but we have to kind of try to do the best we can regarding all this and work together. It's like what Bob Guyton said, you know, you have to spend 10,000 hours with each other so you have mutual trust. And the societies need to do that. And we're doing that with ACC and the whole cardiovascular space. Hopefully for these things, we did it with SCI and AATS as well. And when all four of the major cardiovascular societies are working together, it's pretty powerful, and especially in Washington.
what about, last question, behind the scenes SCS and AATS?
Behind the scenes, STS and ACCS?
Would it be more effective if we, instead of SCS lobbying, AATS lobbying, EACS lobbying, if we somehow
work together.
Well, EX can't lobby in the United States. It's against the law. But
Fair enough.
Our next president of the STS is not able to give it to the PAC because he's Canadian. He gets a check was sent back. I think that's a pretty big question. I'll say what I say, and I'm going to hop off this stage. We probably need to be a single society in 10 years. Thank you.
Fair enough. Thank you. Wow. So our last presentation of this session will involve new technology, harnessing the internet to build your practice, Twitter, YouTube, and Facebook, by Dr. Ed Bender. Dr. Bender.
Morning.
Morning.
Good morning. I appreciate the opportunity to speak to you today on using the internet to build your practice. Here are my disclosures. So you're a brand new surgeon, or maybe not so new, but you've got a brand new technique, and you need a way to get your message out to the masses. This includes your colleagues, your referring physicians, and even your patients. So what do you do? What are your options? There are old ways of doing things, and then there are new ways. Here are the old ways. Mind you, although they're old school, you really can't push these things aside. Giving a scientific presentation at a local or a national meeting is the tried and true way to get academic credibility. Teach a course at your local hospital, medical society, or even meetings like this one. And then there's the sine qua non for academic achievement, that is publishing your work in a credible scientific journal. Those last three methods of growing your reputation still stand, and you have to pay attention to them, and you have to check off those achievements. However, you can add to and accelerate your professional growth by participating in social media and the internet. So what is social media? For those of us really in the audience that are younger than me, the baby boomer generation, please bear with this explanation. For the purposes of this talk, I'll discuss Twitter, which is a microblogging social networking site. I'll discuss YouTube, which is a site where users can upload and view videos, and where participants can comment, rate, and share those video assets. And finally, we'll look at Facebook, which was one of the first social media creations. Participants in this service create a profile for themselves. They post text, images, videos, links to other content, and then the readers can reply to or like or dislike content, and you can friend another participant, which gives you more rights for interaction. So Twitter. When you use Twitter, you identify yourself using what's called a handle, which starts with the @sign, and it is a unique identifier for you. The proper verbiage is that you tweet your thoughts and content. You're limited to 280 characters, but you can tweet other media to expand and enhance your content. Adding a hashtag to a term makes your tweets indexed and searchable. You view tweets on what's called a Twitter client that displays a timeline for those people or entities that you follow. The key to growing your social network is to follow others with similar interests. You make others aware of your presence and the interests because those that you follow are notified that you followed them, and this usually prompts a reciprocal follow. Twitter will also give you suggestions for people to follow based on what is known as the social graph. And here's a rather truncated or abbreviated version of a social graph. In reality, the graph or connections are much more complex. So you can imagine that the power that this form of networking holds for making yourself known throughout the world. Here's an example of a really effective tweet. You can see it's published by one of our hosts, Tom, here, and it represents a new and exciting endeavor. And very importantly, it includes both handles and hashtags that make this not only searchable, but also visible to those who follow those others and the followers of those followers, et cetera, et cetera. So you see, this is not linear networking. This is a geometric networking scheme that results in an exponential growth of communication. As an example of using this new technology to enhance old school ways of telling your story, you can make your academic productivity known to your entire social graph and the social graphs of the members of your graph with a simple tweet. And we've shown that using Twitter as a billboard, if you will, for advertising your scholarly activity enhances readership, and that enhancement lasts through the years. This is good for you, the budding star, and it's also good for our scholarly journals. So boiling it down, Twitter is a vehicle for a physician to gain national and international recognition, to influence the way people think, and to play a role on a global stage, and to do it really, really quickly. So let me switch gears here and talk a little bit about YouTube. This is a video sharing platform. You create what is called a channel for yourself or organization and upload the fruits of your labor. It's a great place to show how you do surgery, and I often look to YouTube to see how it's done. Anybody else in the audience look at YouTube before a case to see what's going on? Yep. Here's a pretty good example. Toru Asai is a cardiac surgeon in Japan, and he has over 2,000 subscribers to his channel, and he produces really high quality, high definition cardiac surgery videos and makes them available for free to viewers on YouTube. For instance, here's a screenshot of a video that Toru published on doing op cabs. Note that he makes a clarification, this is not a slop cab, it's top cab. And the author can add commentary, and people throughout the world can comment and reply to each of these videos, and they're maintained in a viewable list, accessible anytime by anyone. And finally, there's Facebook. In my mind, this is less of a scholarly social media compared to the setup for YouTube and Twitter, but it does offer the advantage of creating groups for specific interests, and those groups can even be private, so only members can contribute. It might be a great platform to interact with each other or with other caregivers. Here's an example of a Facebook group for lung cancer caregiver support. Probably not as germane to growing your professional reputation, but sites like this are important nevertheless, and they allow an interface between patients, family members, caregivers, physicians, and surgeons. So Twitter, YouTube, and Facebook are by no means the only social media platforms out there. There are others like LinkedIn, Snapchat, Instagram, and even more things like Sina Weibo, that is a social media platform in China, much larger than Twitter. And as a physician, you might find different uses for these different platforms. You may use some or none of them, but it's your choice, and it's a great way to establish your brand, communicate with the world, and do it relatively quickly compared to what it was during the old school days. So I thank you very much for your attention, and I appreciate the opportunity to speak.
Are there any questions in the audience as we wrap up the session? I just want to give a couple examples of the power of social media. One, there's been a lot of dialogue about the ischemia trial, back and forth, the merits of it, the controversies of it. And what's been remarkable to me is that trial has not even been published yet. Another example is recently, as we know, Kobe Bryant passed away. And do you guys know how that story was broke? How did you guys find out about it first? CNN? I don't think so. NPR? Nope. It's actually TMZ. TMZ found out about it first. And in some ways, I feel like through the Twitter community, TMZ is a bunch of reporters and kind of that follow folks around. And the Twitter community is like a bunch of TMZ folks because we have people in the room tweeting about the meetings here, people tweeting about the rooms in Twitter. And I'll be honest with you, I didn't attend TCT, but I found a lot of the results from TCT through Twitter and through other social media avenues. And similarly, I think a lot of folks out in the world are going to find out the results of the STS by folks tweeting here before it even hits STS News. So there is a lot of power for it as well. One final comment, and we'll wrap up the session.
I raised my hand when you asked, but I alluded to this in my talk, and I'm wondering your thoughts. I think we also have a responsibility to make sure that people are learning proper technique. And the problem with YouTube and the problem with Facebook is that it's not peer-reviewed. And there's a lot of information that's out there. And if your resident Googles or YouTube searches left upper lobectomy, there's no telling what they're going to be able to see and what technique they're going to be taught. So how do we as an organization, as a society, ensure the quality of these resources? Do we have a responsibility for that? What's your thoughts on this?
Yeah, that's a really key and point and a great question. The fact that all these videos out there are uncurated, some of them are excellent, some of them are plainly horrible. And I think it takes an educated viewer to discover what is good and what is bad. And oftentimes it's not the video in its entirety that you're really interested in. It's a key step or two that you've had a question about. And you like to see how other people handle it, how you safely surround a pulmonary artery during a robotic lobectomy. There are good ways to do it and bad ways to do it, so the viewer has to be an educated viewer also. It's not for the neophyte.
Thank you so much, Dr. Bender. So this session is again titled Avoiding Practice Extinction, and we hope the audience picked up some valuable tools to hopefully avoid the extinction of our important practice as cardiothoracic surgeons. I want to thank all our presenters for attending this session, and as well as all of you for attending this session in the morning. Hope you enjoy the rest of the STS. Thank you.